Hi, good morning, doctors. Today we are on a 14th day of reading Oxford Handbook of General Practice. I'm Dr. Sesha, your study buddy, and we are preparing together for MRCGP AKT exam, International AKT exam. Today we are starting from page number 354, please. Dyspepsia and H. pylori. In any year, up to 40% of the adult population suffer from dyspepsia. 1 in 10 seek their GP advice. Similar to about 10% of these are referred for endoscopy. Causes are GERD or GORD, peptic ulcer disease, stomach cancer. 60% are referred as non-ulcer dyspepsia, functional dyspepsia managed as uninvestigated dyspepsia. Figure 12.2. Rarer causes are esophagitis from swallowed corrosives, esophageal infection, especially in immunocompromised. So most common highest instances GORD or peptic ulcer. Differential diagnosis. Cardiac pain. Difficult to distinguish. Gallstone pain, pancreatitis and bile reflux. Presentations. Common symptoms include retrosternal or epigastric pain, fullness, bloating, wind, heartburn, nausea and vomiting. Examination is usually normal, though there may be epigastric tenderness. Check for clinical anemia, epigastric mass, hepatomegaly, or lymph nodes in the neck. Management is given in figure 12.2. Lifestyle advice. Give advice on healthy eating, weight loss, and smoking cessation. Avoid precipitating factors, example alcohol, coffee, chocolate, fatty foods. Raising the head of the bed and having a main meal well before going to bed may help. Promote continued use of antacids and alginates. Helicobacter pylori, infection associated with GI disease, peptic ulcer disease, gastric cancer, non-ulcer dyspepsia and esophagitis, non-GI disease ranging from cardiovascular disease and hematological malignancy to cord death. Testing for H. pylori. Test and treat all patients with dyspepsia who do not meet the referral criteria. You need to test and treat. Choice of test is limited by availability of ease of access and cost. Community options are serology, urea breath test and fecal antigen test. A 2-week washout period following a PPI is use is necessary before testing for H. pylori with a breath test or a stool antigen test. So if you want to test a patient for H. pylori with a urea breath test, you have to wait 2 weeks before. If you are already giving him a PPI, you have to wait 2 weeks before stopping the PPI use and then testing for H. pylori with a breath test. Eradication clears 80 to 85% H. pylori infections. The first line options are PAC 500 regimen, full dose PPI, omeprazole 20 milligrams BD plus amoxicillin 1 gram BD plus clarithromycin 500 milligrams BD for 1 week. It is PAC regimen. PPI, amoxicillin 1 gram BD, clarithromycin 500 milligrams BD for 1 week. The PMC 250 regimen, full dose PPI, omeprazole 20 milligrams BD, metronidazole 400 milligrams BD, PMC, metronidazole 400 milligram BD plus clarithromycin 250 milligrams BD for 1 week. For more first line options and second line options, see NICE guidelines. So this is the eradication scheme. For more, so do not retest even if dyspepsia remains unless there is a strong clinical need. Retest if needed using a urea breath test. So this is a flow chart for algorithm for management of uninvestigated dyspepsia in general practice. So let's get back to the algorithm. So patient has come with a dyspepsia. New episode of dyspepsia. Whether there is acute GI bleeding? No. No. Whether there is dysphagia or the patient is aged more than 55 years, plus there is weight loss, plus upper abdominal pain or reflux and or dyspepsia. whether there is no dysphagia, no age more than 55, no weight loss, no upper abdominal pain, no reflux or no dyspepsia is present, then you have to check for second line things, that for non-urgent referral, like hematemesis is present, previous gastric ulcer or surgery, continuing need for NSAID treatment, that is, or increased risk of gastric cancer, or anxiety about cancer, or aged more than 55 with treatment resistant dyspepsia or upper abdominal pain and low hemoglobin, or high platelet count plus nausea, vomiting, weight loss, reflux dyspepsia or upper abdominal pain, or nausea, vomiting plus weight loss plus reflex dyspepsia or upper abdominal pain. See, either of these, these are the gastrointestinal conditions: nausea, vomiting, dyspepsia, upper abdominal pain, and weight loss and reflex, along with any increased platelet count or along with any decreased hemoglobin, or whether it is treatment resistant dyspepsia in age more than 55 years. If it is no to any of this, we will see what to do. So, initially, if new episode of dyspepsia is present and no acute bleeding, then we have to check for these. When there is acute GI bleeding, then admit the patient. In case dysphagia or age more than 55, weight loss, upper abdominal pain, reflux or dyspepsia is present, then urgent referral, that is less than 2 weeks referral for endoscopy. Stop NSAIDs, suspend the PPI H2 receptor antagonist for 2 weeks prior to the procedure. So within 2 weeks you have to send for endoscopy, and then you have to stop NSAIDs and suspend the PPIs or H2 receptor antagonists 2 weeks prior to the procedure. So endoscopy will give us a guideline, will give us a picture about what is the problem, right? So then, if at all it does not cover under the urgent referral scheme. So then you have to see these are the conditions for non-urgent referral, like we have seen hematemesis and whether previous gastric ulcer surgery is there, history or surgery, need for NSAIDs, increases from GI cancer, anxiety about cancer, age 55 above, plus either decreased hemoglobin or increased platelets or normal abdominal and constitutional symptoms. If they are yes, then consider routine referral for endoscopy. If still no, then review the medication causes of dyspepsia. So medication causes will be third line. First you have to rule out urgent causes of referral. Second, non-urgent referral causes. Third, review the medication for dyspepsia. Example, calcium antagonist, theophylline, SSRIs, nitrates, bisphosphonates, steroids, and NSAIDs. All of these will cause dyspepsia. If they are causing, then give them lifestyle advice. Review their medicines means change their medicines also. Give them lifestyle advice. And if there is response, then return to self-care. If there is no response after reviewing the medicines or changing the medicines, then give PPI omeprazole for 1 month. If there is no response, then test and treat for H. pylori. If there is response, then return to self-care. If there is no response, then H2 receptor antagonist ranitidine 150 mg BD or prokinetic domperidone 10 mg CDS for 1 month. And if there is response, then low dose treatment PRN to control minimum to control symptoms. In case there is a relapse after H. pylori treatment, then go for again low dose PRN to control symptoms. So on the other end, this comes from. So after low dose treatment also, you have to review after 1 year or maximum number of repeats is used. Then if at all it is taken care of, then return to self-care. If still not taken care of after 1 year, then go for endoscopy. And if there is no response to even H2 receptor antagonist ranitidine, then go for endoscopy. Stop, and for before endoscopy you have to stop NSAIDs and suspend PPI receptor antagonists for PPR H2 receptor antagonist for at least 2 weeks prior to the procedure. So in case of urgent referral, there is no scope of PPI. That's because within 2 weeks only he has to get an endoscopy. Only for non-urgent referral cases, you have to prescribe these medications. Esophageal conditions. Esophagitis. Common condition, reflux of acid from the stomach to the esophagus causes mucosal damage resulting in inflammation and ulceration. Other causes of esophagitis are drugs like NSAIDs, infections, CMV, HSV, um, and Candida, especially in the immunocompromised people. Ingestion of caustic substances. Management. Treat reflux-induced esophagitis as GORD. Other causes, otherwise treat the cause. Barrett's esophagus, page 359 we will see. Chronic benign stricture. Recurrent esophagitis, example, secondary to GORD, NSAIDs and potassium preparations. Scars the esophagus resulting in stricture formation, most commonly in the elderly females. Presentation. Long history of reflux with more recent dysphagia. If obstruction or severe undigested food may be regurgitated immediately after swallowing, may be associated with nighttime coughing, paroxysms due to aspiration of gastric contents to the chest. Examination is usually normal. Management. Refer for urgent endoscopy to confirm the diagnosis and exclude carcinoma. Treatment is by endoscopic dilatation of the stricture. So whenever there is dysphagia, then refer for urgent endoscopy to confirm the diagnosis or excluding carcinoma. Treatment is by endoscopic dilatation of the stricture. Carcinoma of the esophagus. This is in page 362. Presbyoesophagus is common among the elderly. Intermittent sensation that food is getting stuck, usually at the back of the throat. Examination is normal in the SS endoscopy. Barium swallow or esophageal motility studies may reveal esophageal spasm. Reassure them. Globus pharyngeus or globus hystericus. Sensation of a lump in the throat without difficulty in swallowing is common. It may indicate anxiety. Reassure if no organic signs and treat in dyspepsia. If not responding, refer to ENT for exclusion of organic cause. Eosinophilic esophagitis. Chronic allergic esophagitis, males more than females, more common if history of atopy is present. Family history in 7% cases. Most present aged less than 40 years with esophageal dysfunction, dysphagia, food impaction, vomiting, regurgitation, heartburn, abdominal pain. In children may present with failure to thrive or feeding intolerance. If suspected, refer for endoscopy. Esophageal biopsy shows characteristic eosinophilic infiltration. So when you go for a biopsy after endoscopy, it shows eosinophilic infiltration. Treatment is with a PPI for 8 weeks to exclude GOD. If eosinophilic endoscopic changes persist, treatment is with exclusion or elemental diet or topical glucocorticoids. So you give PPI for 8 weeks and exclude GOD. And if endoscopic changes are persisting, then treatment is an exclusion of a triggering diet or elemental diet or start on an elemental diet or give topical glucocorticoids. Esophageal dilatation may be needed in several cases. Esophageal eclasia. This is some type of allergy of the esophagus. See, eosinophilic esophagitis. Failure of relaxation of the circular muscles and the distal esophagus. Peak incidence is 30 to 40 years and females slightly more common than males. Presentation. Gradual onset of dysphagia over the years accompanied by regular regurgitation of stagnant food and foul belching. This is over years. Not acute onset. Nighttime coughing fits are due to aspiration, which can result in recurrent chest infections. Examination is normal, though there may be signs of aspiration pneumonia. Management. Chest X-ray to exclude aspiration pneumonia. Endoscopy confirms diagnosis. Refer for surgery. Plummer-Vinson syndrome, iron deficiency anemia plus dysphagia. Due to a post-cricoid web in the esophagus, females more than males. Peak incidence is 40 to 50 years. Presence with high dysphagia with food sticking in the back of the throat plus retching plus choking sensation. It is a pre-malignant condition, so refer for a biopsy and dilatation of the pharyngeal web. Replace with iron. Pharyngeal pouch is a pulsion diverticulum of the pharyngeal mucosa through the Killian's dehiscence, area of weakness between the two parts of the inferior pharyngeal constrictor. So, males more than females increases with age, usually develops posteriorly, then protrudes uh, to one side, that is left, more common than right. As a pouch gets larger, the esophagus is displaced laterally. Presentation. Left side is more common than right. Presentation. Dysphagia is the presentation for pharyngeal pouch. The first mouthful is swallowed easily, then fills the pouch, which makes further swallowing difficult, accompanied by regurgitation of food from the pouch plus symptoms of aspiration, nighttime coughing, and recurrent chest infections. A swelling is palpable in the neck in 2/3 of the cases. Management. Refer for further investigation. Diagnosis is confirmed with endoscopy or barium swallow. Treatment is surgical. So you do an endoscopy or a barium swallow to check for pulsion diverticulum or for a pharyngeal pouch. In 2/3 of the cases, a swelling is palpable in the neck. Esophageal varices result from portal hypertension and can bleed massively. Admit as a blue light emergency if bleeding is present. Impacted esophageal foreign body. Usually the patient notices that something has stuck resulting in pain, difficulty in swallowing plus retching. If suspected, refer immediately to A&E for further investigation. So this is a true foreign body. Usually the patient notices something has struck in resulting in pain, difficulty in swallowing and retching. If suspected, immediately to A&E for further investigation plus removal of the foreign body. Esophageal perforation is rare, usually a complication of endoscopy. Less commonly due to violent vomiting. The patient becomes very distressed with pain relating to the site of perforation, which is worse on swallowing. Examination reveals tachycardia, shock or pyrexia, breathlessness, surgical emphysema in the neck. Admit as a surgical emergency. Esophageal atresia or tracheoesophageal fistula. 1 in 2,500 live births, 5% have esophageal atresia alone or 5% with tracheoesophageal fistula alone. The remainder have both. Risk factors for sudden infant death syndrome is one of the risk factors for sudden infant death syndrome. Presentation of a TOF or esophageal atresia antenatal at ultrasound or following investigation of polyhydramnios. Antenatal when an ultrasound is done or following an investigation for polyhydramnios. So why there is polyhydramnios? Normally the normally the fetus will swallow the amniotic fluid and then will again urinate into the amniotic fluid, which will be cycling, which will lead to this turnover of your amniotic fluid. But when there is a block anywhere in the GI system and urinary system, then there will be oligohydramnios. When there will be polyhydramnios, because the kidney is normally functioning as far as urination is concerned, but the infant is not able to gulp down the amniotic fluid. Postnatal cough or breathing difficulties in a newborn infant, choking on the first feed, inability to swallow saliva, bubbling of fluid from the mouth, developing soon after birth. Yes, when there is esophageal atresia and you're giving some milk to the newborn infant, then he will not be able to swallow it. So he will either vomit it or choke on it, or there is bubbling of fluid from the mouth soon after birth. Later in childhood, the H-type fistulas where there is no atresia but just a fistula may present late with recurrent chest infections. Management depends. So presentation depends upon the type of communication between the trachea and the esophagus. Management. The diagnosis is confirmed with X-ray. Treatment is surgical. Post-operatively, children may have a barking cough, cough, and or dysphagia, both settle before 2 years of age. Gastroesophageal reflux and gastritis. GERD Caused by retrograde flow of gastric contents to an incompetent gastroesophageal junction. It affects 5% of the adult population. Risk factors are smoking, alcohol, coffee, fatty foods, big meals, obesity, hiatus hernia, tight clothes, pregnancy, systemic sclerosis, drugs, NSAIDs, TCAs, SSRIs, iron supplements, anticholinergics, nitrates, and alendronic acid. Surgery for eclampsia. So now we have done a surgery for eclampsia, but now it is causing regurgitation or reflux. Conditions caused by GOT. Esophagitis, defined by mucosal breaks plus esophageal ulcer, benign esophageal stricture, intestinal metaplasia, that is Barrett's esophagus, esophageal hemorrhage, and anemia. Presentation. Heartburn. Most common symptom, burning retrosternal or epigastric pain which worsens on bending, stooping, or lying down with hot drinks relieved by antacids. Other symptoms are water brush, mouth fills with saliva, reflux of acid into the mouth, especially on lying flat, nausea and vomiting, nocturnal cough, wheeze due to aspiration of reflux contents, stomach contents. Examination usually is normal. Check for clinical anemia. So normally examination is usually examination is normal. So you have to check for any red flag signs like clinical anemia, epigastric mass, hepatomegaly or lymph nodes in the neck, and then refer within 2 weeks to endoscopy. Endoscopy if indicated. So not all cases endoscopy is indicated. So either urgent referral or non-urgent referral endoscopy is indicated. Symptoms are poorly correlated with endoscopic findings. Reflux may remain silent in patient with Barrett's esophagus, but heartburn can severely affect quality of life in patient with negative endoscopy results. So initial management in all the cases given lifestyle advice. Um, if diagnosis is clinical, that is the patient presents with the reflux-like symptoms treated for uninvestigated dyspepsia, then we have to follow the figure 12.2. If reflux is confirmed on endoscopy, offer treatment with a PPI omeprazole 20 milligrams OD for 1 to 2 months. So it is 8 weeks treatment with PPI for GORD. If esophagitis at endoscopy and still symptomatic on standard dose PPI, double the dose of the PPI omeprazole 20 milligrams BD for another further 1 month. So in GORD, first, if and reflux is confirmed on endoscopy, then you give 1 to 2 months of PPI normal dose, and even after that esophagitis is present on endoscopy and still symptomatic on normal dose PPI, then give double the dose for 1 more month. If inadequate response to PPI, try a H2 receptor antagonist, example ranitidine, or add a prokinetic like metoclopramide 10 milligrams TDS for 1 month. So initial 1 to 2 months give only PPI normal dose, then give a double dose for 1 more month, and if still no response, then change to a H2 receptor antagonist or add a prokinetic. Long-term management of endoscopic or barium confirmed GORD. So this is for confirmed GORD. Patients who had dilatation of an esophageal stricture should remain on long-term full-dose PPI therapy. For all other patients, if symptoms recur following initial treatment, offer a PPI the lowest dose possible to control the symptoms with a limited number of repeat prescriptions. Discuss using the treatment as on required basis to manage symptoms. Refer for consideration of surgery if quality of life remains significantly impaired despite optimal treatment, or if patient does not wish to continue PPI or H2 receptor antagonist therapy long term. Surgery of any type, more than 90% successful, although results may deteriorate with time. Hiatus hernia is common in 30% over 50 years of age. 50% have GORD. Obesity is a risk factor. The proximal stomach herniates through the diaphragmatic hiatus into the thorax. 80% is having a sliding hiatus hernia, that is more common, where GORD slides into where the gastroesophageal junction slides into the chest. 20% are having rolling hernia where a bulge of the stomach herniates into the chest alongside the esophagus. The gastroesophageal junction remains in the abdomen. Management: treat as GORD. Barrett's esophagus. Usually found incidentally at endoscopy for symptoms of GORD and caused by chronic GORD. The squamous mucosa of the esophagus undergoes metaplastic change and the squamocolumnar junction appears to migrate away from the stomach. The length affected varies, associated with increased risk of adenocarcinoma of the esophagus. Consider referral for endoscopic surveillance. If there is dysplasia is present on initial endoscopy, then you have to refer for endoscopic surveillance. Dysplasia on endoscopy, other risk factors like male, older age, increased length of Barrett segment. So age is more and length of segment is also more. Treatment is with long-term PPIs, omeprazole 20 to 40 milligrams OD plus laser therapy plus resection, depending upon the length of the segment and depending upon the severity of the case. But you have to send them for endoscopic surveillance. Acute gastritis. Mucosal inflammation of the stomach with no ulcer. Type A. Affects the entire stomach associated with pernicious anemia and premalignant condition. Pernicious anemia, which is premalignant condition, is a cause of acute gastritis. Type B. Affects the antrum, the duodenum, antrum and the duodenum associated with H. pylori. Type B gastritis. And type C. Due to irritants, that is NSAIDs, alcohol or bile reflux. Presentation and investigation. As for dyspepsia. Management. Treat the cause of possible H. pylori, cause of the possible. So if it is type A, you have to treat the anemia, pernicious anemia. Type B, treat the H. pylori. Type C, treat the cause, NSAIDs, alcohol or bile reflux. H. pylori eradication, reduction of alcohol. Acid suppression, H2 receptor antagonist, ranitidine or nizatidine or PPI for 4 to 8 weeks. Re-endoscopy to confirm healing. Complications: hemorrhage, gastric atrophy plus gastric cancer, type A only. Complications are hemorrhage, there could be a gastric atrophy, plus or minus there could be a gastric cancer with type A, that is with pernicious anemia, type A. Peptic ulceration. Peptic ulceration is a term which includes both gastric and duodenal ulceration. Most patients present with dyspepsia. Specific features of gastric and duodenal ulcers are listed in table 12.6. Management. For patients not taking NSAIDs, eradicate H. pylori if present. So peptic ulcer and patient is not taking NSAIDs, so eradicate H. pylori. Speeds ulcer healing and decreases the relapse. Confirm eradication with a urea breath test for a duodenal ulcer or repeat endoscopy for a gastric ulcer and retreat if still present. You retreat if it is still present. That is, it is not healed by H. pylori eradication. If H. pylori is negative, treat for with full dose PPI omeprazole 20 milligrams OD for 1 to 2 months. If gastric ulcer, re-endoscopy to check the ulcer is healed. So whenever there is a gastric ulcer, you have to be extra cautious. You have to do re-endoscopy to check whether it is healed or not. And whether if it is not healed or still present, you have to retreat. You should not give any escalating medicine. For patients taking NSAIDs, stop NSAIDs where possible. If not possible, consider changing to a safer alternative, that is paracetamol, reduction of dose of NSAIDs, COX-2 selective NSAIDs, and adding a gastric protection or a PPI or a misoprostol. Offer full dose PPI or H2 receptor antagonist, H2RA therapy for 2 months. If H. pylori is present, subsequently offer eradication therapy. Check eradication with repeat endoscopy, gastric ulcer or urea breath test for a duodenal ulcer. For a duodenal ulcer, you need not do a repeat endoscopy for checking of resolution. But for gastric ulcer, you need to repeat an endoscopy for eradication of H. pylori or the ulcer. For all patients, lifestyle measures: avoid foods or alcohol which exacerbate the symptoms. Eat little or often and often. Avoid eating less than 3 hours before food. Stop smoking. Before bed, stop smoking. If symptoms recur following initial treatment, offer a PPI as the lowest dose to control symptoms with a limited number of repeat prescriptions. Discuss the use of using treatment plans on a PRN basis. Offer a H2 receptor antagonist therapy if there is inadequate response to your PPI. In the patients with unhealed ulcer or continuing symptoms despite adequate treatment. So this is where you were asked to retreat. Exclude non-adherence to the medication. Exclude a malignancy. Exclude failure to detect H. pylori. Inadvertent NSAID use or other ulcer-inducing medication, and rare causes is Jollinger-Ellison syndrome or Conn's disease. So here where you are asked to retreat after a H. pylori eradication, if still there is an ulcer is present, then retreat, and if H. pylori is negative, um, and you give full dose treatment of PPI 1 to 2 months, and if gastric ulcer is present, re-endoscopy. In these cases, if there is no response, so in that case, you have to exclude non-adherence to the medication, malignancy, failure to detect a H. pylori in an initial step, inadvertent NSAID use means he is continuing NSAID use despite of these symptoms of ulceration, other ulcer-inducing medication, rare causes or Jollinger-Ellison syndrome or gastrinoma, Conn's disease. Once symptoms are controlled, review at least annually to discuss symptom control, lifestyle advice, and medication. Refer if gastric ulcer fails to heal or if symptoms do not respond to medical treatment. Possible surgical procedures include gastrectomy, vagotomy, drainage procedure, highly selective vagotomy. Jollinger-Ellison syndrome associated with association of peptic ulcer with a gastrin secreting pancreatic adenoma, rarely duodenal in location. 50 to 60% are malignant, 10% are multiple, 30% associated with multiple endocrine neoplasia, 1. Men 1 associated with gastrinomas or Jollinger-Ellison syndrome. Incidence is 0.1% of the patient with duodenal ulcer disease. Suspect in those with multiple peptic ulcers resistant to drugs, particularly associated with diarrhea, steatorrhea, or family history of peptic ulcers, or islet cell pituitary or parathyroid adenomas, or they have pancreatic islet cell adenomas, pituitary adenomas, or parathyroid adenomas. See, whenever there is a family history, you have to check for Men's syndrome. Refer for further investigation. Treatment is with PPIs, omeprazole 10 to 60 milligrams. See, never we have seen a 60 milligram dose of omeprazole, but in case of Jollinger-Ellison syndrome, you have to give 10 to 60 milligrams BD plus or minus surgery. Features of gastric and duodenal ulcers, GU and DU. Population group typically affects the middle-aged elderly male patients, gastric ulcer. Risk factors of gastric ulcer are H. pylori 70 to 90%, NSAID use increased risk 3 to 4 times, delayed gastric emptying and reflux from duodenum by increased by smoking. Presentation may be asymptomatic, epigastric pain worsened by food, helped by antacids or lying flat plus weight loss with complications which are mentioned below. On examination, an uncomplicated gastric ulceration. Examination usually normal, although there may be epigastric or left upper quadrant tenderness. See, it is left upper quadrant tenderness. Investigations is as for dyspepsia. Complications are bleeding, acute GI bleeding, leading to iron deficiency anemia, perforated peptic ulcer. Duodenal ulcer is perforated more than gastric ulcer. GUs may perforate posteriorly into the lesser sac. DUs usually perforate anterior into the peritoneal cavity. There may or may not be past history of indigestion. Vessels with sudden onset severe epigastric pain which rapidly becomes generalized. When the GU perforates into the lesser sac, symptoms may remain localized or be confined to the right side of the abdomen. So in GU perforation, symptoms may remain confined to the right side of the abdomen. Examination. Generalized peritonism with broad board-like rigidity. Management. Acute surgical admission. Pyloric stenosis in adults is a complication of duodenal ulceration. Duodenal stenosis secondary to scarring from chronic DU, characterized by copious vomiting of food 1 to 2 days old. There may or may not be a past history of indigestion. Examination. Prolonged vomiting may be evidence of dehydration plus or minus weight loss. Succussion splash may be audible. in case of pyloric stenosis in adults. Management, surgical referral for confirmation of diagnosis and surgical relief. So let us see now the features of duodenal ulcer disease. Typically affects young, middle-aged males, although can affect adults, any adults, males more than females. So basically, this gastric ulcer and duodenal ulcer are affecting mostly the males because males take more stress. So stress induce also. H. pylori more than 90% of the cause in both GU and PU. NSAID use associated with duodenal ulcer also. Gastric hyperacidity. So whenever there is excess acid in the gastric in the stomach, that will also cause erosion of the duodenal mucosa. So any hyperacidity causes like Jollinger-Ellison syndrome, etc. Rapid gastric emptying, smoking, and stress. They're saying stress is a time bomb. And smoking. Smoking also causes duodenal ulcer. Presentation may be asymptomatic or spontaneously relapse and remit. Epigastric pain, typically relieved by food, worse at night, plus in weight gain because food is causing relief of pain, so patient eats more and more. So there is weight gain plus a water brush or saliva fills the mouth. Fills with complications as seen below. In uncomplicated duodenal ulceration, the examination is usually normal, though there may be epigastric tenderness. And complications are same: bleeding, perforated ulcer, um, pyloric stenosis in adults. Gastroesophageal malignancy, page number 362. Carcinoma of the esophagus, common cancer accounting for 7,500 deaths per year. In the UK, most common patients more than 60 years. Overall, uh, male to female ratio is 5:1. So, males, GI cancers, more in males. Usually presents gastroesophageal malignancies more in males, usually present late when prognosis is poor. Two types are there. Squamous cell carcinoma, 50% of the cases, predominant form in the upper two-thirds of the esophagus. Adenocarcinoma, 50% of the patients, predominant in the lower one-third of the esophagus. Incidence is more in adenocarcinoma, and male to female ratio is also 5:1. Common risk factors: squamous cell carcinoma, smoking, alcohol, low fruit or vegetable intake, whereas in adenocarcinoma, smoking is a cause, obesity, low fruit or vegetable intake, GORD, particularly Barrett's esophagus, risk increases by 30%, 30 times. The longer the affected segment, the higher the risk. Decreased risk to that of a non-smoker 10 years after giving up. Reduction in risk to that of a non-smoker 10 years after giving up smoking. Other risk factors: previous mediastinal radiotherapy increases the risk 2 times for patients treated for breast cancer, increases the risk for 20 times for patients treated for non-Hodgkin's lymphoma. Plummer-Vinson syndrome or Patterson-Kelly syndrome, esophageal web and iron deficiency anemia is another risk factor for esophageal carcinoma. Tylosis is a rare inherited disorder with hyperkeratosis of the palms. 40% develop esophageal cancer. Presentation: a short history of rapidly progressive dysphagia. So now here it is a rapidly progressive dysphagia affecting for solids initially and then solids and liquids. So whenever there is a mass obstructing your esophagus, the liquids can pass through but solids have difficulty in passing. So initially there will be dysphagia for solids, and then when the mass is completely blocking the esophagus, then even liquids are difficult to pass. There will be weight loss, regurgitation of the food, and fluids may be blood stained. Retrosternal pain is a late feature. Other symptoms include hoarseness and cough due to aspiration or fistula formation. Examination may be normal. Look for evidence of recent weight loss, hepatomegaly, or cervical lymphadenopathy. Management: refer for urgent endoscopy if suspected. Rapid access dysphagia clinics are run in many areas. Specialist management involves resection, treatment of choice, but only one-third of the patients it is suitable. Chemotherapy, radiotherapy, or palliation with a stenting tube. Tubes commonly become blocked. Good palliative care is essential. Refer early. 1011. Overall, 8% 5-year survival. So this is very less. 8% 5-year survival rate. It's very less for esophageal carcinoma. Stomach cancer. Stomach cancer, 5,000 deaths in UK. 95% are adenocarcinomas. This is affecting older people with 92% diagnosed beyond 55 years of age. Males more than females. Incidence has more than halved over the past 30 years in the UK, probably due to improved diet. Other risk factors include geography. Commonly in Japan, blood group A blood group is more prone for stomach cancer. H. pylori infection is not clear if eradication decreases the risk. Atrophic gastritis, pernicious anemia, smoking, adenomatous polyps, social class, and previous partial gastrectomy. So these are the risk factors, other risk factors for stomach cancer. Presentation, often non-specific. Presents with dyspepsia. So this is not dysphagia. Stomach cancer, dyspepsia, weight loss, anorexia or early satiety, vomiting, dysphagia, anemia. Again, dysphagia is also present. Vomiting, anemia or GI bleeding. Suspect any patient more than 55 years with recent onset dyspepsia within 1 year and or other risk factors. Examination is usually normal until incurable. Look for epigastric mass, hepatomegaly. Look for epigastric mass, hepatomegaly, jaundice, ascites, enlarged lymph nodes of Virchow's node, acanthosis nigricans. Acanthosis nigricans most commonly metabolic syndrome. Second most common is gastric cancer. Management: if suspected, refer for urgent endoscopy. In early stages, total partial gastrectomy may be curative. Most present in later stage, overall 5% survival is 15%. See, survival is very less in gastric cancer also. Post-gastrectomy syndromes. So abdominal fullness, a feeling of early satiety and weight loss, advised to take small frequent meals, bilious vomiting, affects 10% of patients post-gastrectomy, intermittent sudden attacks of bilious vomiting 15 to 30 minutes after eating, or plus or minus epigastric cramping pain relieved by vomiting. You should settle spontaneously. Metoclopramide may be helpful in the interim if symptoms are severe or fail to settle, requires surgical review. Surgical bile diversion or stomach reconstruction may alleviate the symptoms. Dumping, abdominal distension, dumping syndrome, post-gastrectomy, dumping syndrome, abdominal distension, colic, vasomotor disturbance, example sweating and fainting after meals, affects 1 to 2% of the gastrectomy patients, more commonly early after surgery, most settle within 6 months. Two types. Early dumping syndrome due to rapid gastric emptying starts immediately after a meal, consists of sweating, flushing. Early dumping syndrome: sweating, flushing, tachycardia, palpitations, epigastric fullness, and nausea. See, there's a very small stomach, so what happens when you're eating food rapidly? Then it is getting dumped into the esophagus without digestion. So, sweating, flushing, tachycardia, palpitations, epigastric fullness, and nausea. Occasionally, there may be vomiting and diarrhea, plus or minus colicky abdominal pain. Advise small dry meals with restricted carbohydrate intake. Take drinks in between meals. If severe, refer. Late dumping syndrome due to rapid gastric emptying. See, both are due to rapid gastric emptying and hyperglycemia. So, this is when there is rapid gastric emptying and hyperglycemia, the resultant hyperinsulinemia causes rebound hypoglycemia. Starts 1 to 2 hours after the meals, consists of faintness, sweating, tremor, and nausea. Advise the patients to decrease the sugar content of the meals. In both the early and late dumping syndromes, you have to decrease the carbohydrate or sugar content of the meals. Rest for 1 hour after each meal and take glucose if symptoms occur. If severe, refer. Late dumping is due to rapid emptying as well as hyperinsulinemia because of hyperglycemia after intake of meals. Early dumping is immediately after a meal. Late dumping is 1 to 2 hours after meals. Diarrhea post gastrectomy. 50% patients who had a truncal vagotomy or gastrectomy suffer from frequency of defecation. 5% require treatment. The diarrhea is typically episodic and unpredictable. The exact mechanism is not clear. Treatment is with codeine phosphate. So whenever you're having diarrhea after post-gastrectomy, you give codeine or loperamide PRN. The antibiotic treatment is occasionally unsuccessful. Seek expert advice. Surgical measures are rarely necessary. Anemia. Gastrectomy can cause both vitamin B12 deficiency and iron deficiency anemia. Prophylactic vitamin B12 injections may be advised by the operating surgeon. Many advise iron supplements for life. An annual FBC to monitor for anemia is advisable. Treat for iron and vitamin B12 supplementation. Stomach cancer. The risk of stomach cancer increases after partial gastrectomy, 2 times after 20 years and 7 times after 45 years. Hernias. Irreducible hernia. Most type of hernia may become irreducible. It may be the first presentation of a hernia or complication of a long-standing hernia. If obstructed or incarcerated or strangulated blood supply to the bowel contained within the hernial sac is compromised, the hernia is tender and there are signs and symptoms of small bowel obstruction. If you are unable to reduce a hernia, admit for surgical assessment. So if it's irreducible, you admit for surgical assessment. Inguinal hernia. Protuberance of the peritoneal contents through the abdominal wall where it is weakened by the presence of the inguinal canal. Common condition in males more than females which can occur at any age. Presentation. There is a lump in the groin plus discomfort on straining, standing of any length of time. There may be a distinct precipitating event like heavy lifting. Risk factors include chronic cough, COPD, constipation, urinary obstruction, heavy lifting, ascites, previous abdominal surgery. These are the risk factors for inguinal hernia. In urinary obstruction may lead to straining, constipation may lead to straining, chronic cough can cause pressure on the abdomen, heavy lifting can cause straining on the abdominal wall, ascites causes stretching of the abdominal wall, and previous abdominal surgery, which will be the place for herniation. Indirect hernia 80% follows the course of the spermatic cord or the round ligament down into the inguinal canal through the internal inguinal ring located at the midpoint of the inguinal ligament 1.5 centimeters above the femoral pulse and sometimes through the external inguinal ring into the scrotum or vulva. Direct hernia, it passes through a defect in the abdominal wall into the inguinal canal. Rare in children, more common in the elderly. So indirect, it follows this part of the spermatic cord from the internal ring to the external ring into the scrotum of vulva. While direct, it passes through the posterior wall of the inguinal canal through a defect in the abdominal wall. Differential diagnosis of groin lumps given in table 12.7. Examination. Examination of a patient standing up. Look for a bulge in the groin above the line of the inguinal ligament. Unless incarcerated, the lump should have a cough impulse. Check that you are able to reduce the hernia. Sometimes it is easier if the patient lies down to reduce the hernia. Ask the patient to reduce the hernia if you cannot. Management. Small hernias often require no treatment. For larger hernias and smaller hernias that are symptomatic, consider referral for surgical repair. Various methods are used. All have high levels of success, less than 2% recurrence rates. Trusses can be useful for symptomatic hernias in elderly patients, those who are unfit for surgery while awaiting surgery that can be prescribed on the NHS. So inguinal hernias in children we will see in 868. Femoral hernia, less common than inguinal hernia, and females more than males. Femoral, F is for females, F is for femoral, and the patient is usually elderly although can occur at any age. Peritoneal contents protrude down through the femoral canal. Risk of strangulation is high. Presence as a painful lump in the groin or small bowel obstruction. Examination. A rounded swelling medially in the groin lateral to the pubic tubercle. If reducible, a soft palpable lump remains after reduction. Management, always refer for urgent surgical repair. Femoral hernia, always urgent surgical repair. Admit a surgical emergency if obstructed or irreducible. Whereas in inguinal hernias, small hernias and large hernias, we have a classification which requires treatment, symptomatic and all. But whereas femoral hernia, every femoral hernia, urgent surgical repair, admit a surgical emergency because there's most chance of incarceration or strangulation. Differential diagnosis of groin lumps. Position related to the skin. Groin lump, position in relation to the inguinal ligament. In the skin, there's a lump in the groin in the skin, then it could be a lipoma, fibroma, hemangioma or other skin lumps. Their position will be above or below the inguinal ligament. Deep to the skin, femoral or inguinal lymph nodes. If they are lymph nodes, their position can be above or below the inguinal ligament. Saphenous varix of the femoral vein. The position will be below the inguinal ligament. Femoral artery aneurysm will be below the inguinal ligament. Femoral hernia will be below the inguinal ligament. Inguinal hernia will be above the inguinal ligament. Incisional hernia. Breakdown of the muscle closure in an abdominal wound sometimes after surgery. There may be history of wound sepsis, hematoma or a breakdown. Present with bulge at the site of the operation scar plus or minus discomfort. Examination. The hernia is usually visible when patient stands. It can be made more obvious by asking the patient to cough or straight leg raise while lying flat. The margins of the muscular defect are palpable under the skin. Note whether fully reducible or not. Management often reassurance suffices. If obstructed or strangulated or causing discomfort, then refer for surgical assessment. Umbilical hernia. Most common, so reassurance is more sufficient for an incisional hernia, and if it is causing discomfort or it is obstructed or strangulated, then refer for a surgical assessment. Umbilical hernia, most common in infants. In adults, umbilical hernias presenting as a bulge adjacent to the umbilicus may occur due to weakness in the linea alba, females more than males. For adults for surgical assessment, usually repaired as the risk of strangulation is high. Admit as a surgical emergency of obstructed or irreducible. Epigastric hernia. This is for adult umbilical hernias. In infants, we can see in page 868. Epigastric hernia. Midline hernia through a defect in the linea alba above the umbilicus never contains the bowel, usually symptomless, although occasionally causes epigastric pain and vomiting. Examination epigastric mass with a cough impulse, refer for surgical repair. Spigelian hernia. In this, a hernial sac protrudes lateral to the rectus sheath, midway between the umbilicus and the pubic bone. So, epigastric hernia is above the umbilicus and spigelian hernia is between the umbilicus and the pubic bone, midway through the rectus sheath. Presence with discomfort plus or minus vomiting, refer for surgical repair. Obturator hernia protrudes from the pelvis through the obturator canal, usually presents with strangulation or pain, refer to the knee, admit for surgery. Richter hernia, a knuckle of the side wall of the gut, knuckle of the side wall of the gut gets caught in the hernial sac and becomes strangulated, but the bowel is not obstructed. See, only a small portion of the bowel wall is strangulated in a hernia, but the bowel wall is not completely obstructed. This presents with abdominal pain which rapidly becomes worse, plus or minus shock. Admit for acute abdomen. Diagnosis is usually made at surgery. Because in this case there is no classical symptoms of obstructed bowel. So diagnosis is difficult to make. Inguinal ligament runs from the pubic tubercle medially to the anterior superior iliac spine laterally. 366. Appendicitis and small bowel disease. Acute appendicitis, most common surgical emergency in the UK. Peak age is 10 to 30 years. Presents with a central abdominal colic that progresses to localize in the right iliac fossa. Pain is worse on movement, especially during coughing and laughing, and associated with anorexia, nausea, and vomiting. anorexia, nausea and vomiting, and dysuria, constipation or rarely diarrhea. Assessment. Watch for discomfort on walking stooped, may be flushed or unwell, pyrexial 37.5 degrees, furred tongue or fetor oris. There's a furred tongue or a fetor oris, tenderness, rebound tenderness, so there is tenderness, there is rebound tenderness and guarding in the right iliac fossa, especially over the McBurney's point, two-thirds of the distance between the umbilicus and the anterior superior iliac spine. Pain is the pain in the right iliac fossa and palpation of the left iliac fossa, that is called Rovsing sign. Urine analysis is normal or positive for protein and or leukocyte esterase but negative for nitrates. Differential diagnosis of appendicitis. It could be mesenteric adenitis also, gastroenteritis also, Meckel's diverticulum, intussusception, again in the right iliac fossa, Conn's disease, urological causes like UTI, testicular torsion, gynecological causes like pelvic inflammatory disease or ectopic pregnancy, non-abdominal causes, example, otitis media, diabetic ketoacidosis and pneumonia. These can also cause pain in the abdomen and can mimic appendicitis. Management. Admit as a surgical emergency. Expect to be wrong half of the time. Complications. Generalized peritonitis secondary to perforation, appendicular abscess, appendicular mass, subphrenic abscess, female infertility. Appendicitis in pregnancy. Appendicitis affects 1 in 1000 pregnancies. Mortality is high and perforation more common, 15 to 20% during pregnancy. Fetal mortality is 5 to 10% for simple appendicitis, 30% when there is a perforation. Due to the pregnancy, the appendix is displaced. Pain is often felt in the paraumbilical region or subcostally. Admit if immediately if suspected. Children with appendicitis. Symptoms and signs of appendicitis may be atypical, especially if very young. As children localize pain poorly, signs of peritonitis may be difficult to elicit. If unsure of diagnosis, the child is unwell, admit. If unsure of diagnosis, the child is well, arrange for a review a few hours later or ask for carer to contact you if there is any deterioration or change in symptoms. So, mesenteric adenitis. So, the classic signs of appendicitis are not there, and the children cannot even localize these signs of appendicitis or peritonitis. So, that's why you have to be extra cautious. If you are unsure of the diagnosis and child is not well, you admit. If child is well, then ask the carer to contact if there is any deterioration or change in symptoms. Mesenteric adenitis. Inflammation of the mesenteric lymph nodes causing abdominal pain in children may follow an upper respiratory tract infection, can mimic appendicitis. Check MSU to exclude UTI. If guarding or rebound tenderness is present, refer for acute surgical assessment. So, guarding and rebound tenderness mostly indicates a surgical emergency. So, refer for surgical assessment. Settle spontaneously with simple analgesia and fluids. If not settling, 1 to 2 weeks for 1 to 2 weeks, refer for pediatric assessment. Mesenteric adenitis. Subphrenic abscess rarely follows 7 to 21 days after generalized peritonitis, particularly after acute appendicitis. Presents with general malaise, swinging fever, nausea and weight loss, pain in the upper abdomen radiating to the shoulder tip. Breathlessness can be associated due to reactive pleural effusion or lower lobe collapse. Examination is subcostal tenderness plus or minus liver enlargement. FBC's raised WCC. If suspected, admit the patient in subphrenic abscess. Meckel's diverticulum. It's a remnant of the attachment of the small bowel to the embryonic yolk sac. It is 2 inches long, 2 foot proximal to the appendix and presents in 2% of the population. So Meckel's diverticulum is not present in the large intestine. It is present a part of the small intestine. A Meckel's diverticulum may not cause any problems or cause an appendicitis-like picture, acute intestinal obstruction or GI bleeding. Symptoms can occur at any age but are more common in children. Intussusception. Crohn's disease, celiac disease, obstruction and ischemia. Adhesions. Adhesions arise as a result of intra-abdominal inflammation. Bowel loops become adherent to each other, omentum, mesentery, and abdominal wall. Fibrous bands may form connecting the adjacent structures. Presence with abdominal pain plus obstruction. Causes are could be an intra-abdominal surgery, intra-abdominal sepsis, appendicitis, cholecystitis, salpingitis, inflammatory bowel disease, endometriosis. Refer for a surgeon. Treatment is difficult as any surgery may result in new adhesions. Conservative management with analgesia and stool softeners is preferred. Laparoscopic or rarely open division of adhesions is occasionally necessary. So we will stop here. Our next topic would be intestinal non-Hodgkin's lymphoma. We are stopping here at page number 367 for today, and then we will continue from 367 tomorrow. Thank you. Have a good day.